So lungs are enclosed in the pleural cavity, and pleura is a serous membrane which lines the pleural cavity. Okay, so here the hand is representing the lung, and it is invaginated into this fluid filled balloon like structure. This represents the pleura. So if you push the hand through the fluid filled balloon, this balloon will surround the hand like this. So this membrane-like structure is representing the pleura. So here is the lungs surrounded by the pleura. Okay. So it has two layers. Inner visceral layer covers the lungs. See, this part which is covering the lung is the visceral layer or visceral pleura. And outer parietal pleura lines the thoracic wall and the mediastinum. So this part which is lining the thoracic wall and the mediastinum, this is parietal pleura. This is heart, this is diaphragm. Okay, there are divisions of parietal pleura. We will discuss. And both the layers of pleura are continuous with each other at the hilum of the lung and along the pulmonary ligament. Okay. Pulmonary ligament is lying below this lung root. Lung root here, trachea is bifurcating into two principal bronchi. So below this lung root, there is extension of some pleural reflection that forms the pulmonary ligament. This is how the pleural cavity develops. The lung bud insinuates within the pleural cavity to form this pleural fluid filled pleural cavity surrounding the lung during development. Okay. So here it has been cut open. Outer one is the parietal pleura, inner one is the visceral pleura. Okay. Here also you can see this is transverse section through the thorax. This part is the heart and pericardium, mediastinum mainly. So this blue one surrounding the thoracic wall and mediastinum, that is parietal pleura. Pink one is the visceral pleura surrounding the lung, and these are the lung roots where the structures are entering into the lung and coming out from the lung. What are you talking? You come here in front. Come here. এখানে এসে বস, সামনে ব্ল্যাক চেয়ারে, এদিকে উঠে আয়, বসে থাক তখন। Okay, so first this pleural sacs are formed. Lung part are developing from the laryngotracheal tube. From the end of this tube, two lung buds are forming. They are gradually invaginating into this pleural sac to form the lung. Okay, and that's how the pleura is divided into visceral and parietal pleura. So this green portion is gradually forming the visceral pleura, and this blue lining is forming the parietal pleura, and this is the invaginating lung bud. Okay, understood? So this picture represents the development of visceral and parietal pleura, and invagination of lung in the pleural sac equates the invagination of first fist in the balloon in the previous picture. So here complete development of parietal and visceral pleura have occurred. So if pleura can come as a short note, okay, parietal or visceral pleura, so you practice a schematic diagram like this. So lung tissue, this green portion representing visceral pleura, the blue one representing the parietal pleura, and here are the lung roots of the lung, where the bronchial trachea is bifurcating into two principal bronchi. So how the pleural cavities are developing during embryonic life, fetus has two pleural sacs here. Each developing lung bud invaginates one pleural sac and gets covered by two layers of pleural sac. Later, the lung bud expands to form the lung and start occupying the pleural sac. Layer of the pleural sac covering the lung forms the visceral pleura, whereas outer layer forms the parietal pleura. And a thin persistent space between the two layers of pleura, it forms the pleural cavity. Okay, so that's how the layers of pleura and pleural cavity is formed. Okay, visceral pleura is developed from splanchno-pleuric layer of lateral plate mesoderm, and hence it receives blood supply and nerve supply from the lungs, that is autonomic supply. Okay, and parietal pleura is developed from the somatopleuric layer of lateral plate mesoderm, and hence it receives blood supply and nerve supply from the thoracic wall, that is somatic nerve. So parietal pleura, if injury occurs in parietal pleura, it will be painful because of the somatic supply, but visceral pleural injury is not painful because supplied by the autonomic nerves. And left pleural cavity is smaller than the right one due to the smaller size of the left lung. Here different divisions of the parietal pleura has been shown. See this part which is covering the mediastinum, that is known as mediastinal pleura. Here is the cervical pleura covering the apex of the lung. Here surrounding the thoracic wall, this part is known as the costal pleura. The whole green portion is the costal pleura, and this pink portion covering over the diaphragm, it is known as diaphragmatic pleura. So parietal pleura is divided into 4 parts: mediastinal pleura, cervical pleura, costal pleura, and diaphragmatic pleura. Okay, this is very frequently asked in your viva also in lung viscera, or in case of thorax ospi, like this it can come. So pleura consists of 2 layers: inner visceral layer, outer parietal layer. This is schematic presentation of the parietal pleura. This is first rib. Above this first rib lies the apex of the lung. So this apex of the lung is covered by the cervical pleura, this light blue colored one. Here is the mediastinal pleura, violet colored one. The green colored one is the costal pleura or costovertebral pleura, and the pink one surrounding the diaphragm is the diaphragmatic pleura. So these are the 4 parts of the parietal pleura. So parietal pleura is thicker than the visceral pleura, and it has 4 parts or subdivisions. These are the 4 parts: costal or costovertebral pleura, diaphragmatic pleura, mediastinal pleura, and cervical pleura. Okay. So we will discuss the individual parts in details. First, the costovertebral pleura, previous name was costal pleura, lines the inner surface of the thoracic wall and separated from the thoracic wall by the endothoracic fossa. Endothoracic fossa is generally not a sheet-like structure. It is a thin layer of connective tissue. Okay, separating the costal pleura from the thoracic wall. Next is diaphragmatic pleura. It is firmly adherent to the superior surface of the diaphragm. Here is the diaphragmatic pleura. Continues on the sides with the costovertebral pleura. Here it is continuous with the costovertebral pleura, and medially with the mediastinal pleura. Here is the mediastinal pleura. Okay. Next is cervical pleura, also known as copula. Okay. It is a dome-shaped part of pleura. Here is the cervical pleura. Covers the apex of the lung and extends into the root of the lung about 5 cm above the first costal cartilage. It is covered superiorly by the suprapleural membrane. It is covered by the suprapleural membrane or Simpson's fossa. This is important, suprapleural membrane. Next we go to the mediastinal pleura. It covers the medial surface of lung from lateral boundary of the mediastinum. So this part is mediastinal pleura, covers the medial surface of the lung from the lateral boundary of the mediastinum. Continuous with the pulmonary visceral pleura along the hilum of the lung and pulmonary ligament. Okay. Here was the root of the lung. So along the root of the lung, it will be continuous with the visceral pleura. You have seen in the previous pictures. See here, this is the pleural reflection surrounding the root of the lung, and this downward deflection of these two layers of pleura, it is forming the pulmonary ligament. And here you can see around the root of the lung, the parietal pleura is continuous with the visceral pleura. Okay, understood? So root of the lung here containing the apatrial and hypatrial bronchus, pulmonary vein, superior pulmonary artery and inferior pulmonary artery. So all these structures are forming the root of the lung. This is root of the lung of the right side. So what is pulmonary ligament? It is also asked in your viva in lung viscera. Today in dissection portion we will see the lung viscera. Okay. So you look over the lung viscera. So pulmonary ligament, it is a double layered fold of parietal pleura, extends inferiorly from the root of the lungs. See here, double layered fold of parietal pleura extends inferiorly from the root of the lungs. Along the root of the lung and pulmonary ligament, the parietal pleura is continuous with the visceral pleura. Okay. What are the contents? Contents are space of the pulmonary ligament is filled with loose areolar tissue, few lymphatics and sometimes accessory bronchial artery. So these are the contents of pulmonary ligament. It is asked in your viva, what are the contents? Filled with loose areolar tissue, few lymphatics and sometimes accessory bronchial artery. These are the contents of pulmonary ligament. So we have understood the location of pulmonary ligament, extension just below the root of the lung, formed by double layered of the pleura. Now this is surface marking of pleura. We will discuss in surface marking class. Okay. Yes. Where the structures are entering and coming out from the lung. This is hilum of the hilum is that part of the lung. It is a root of the lung. Root of the lung is entering through the hilum of the lung. যেটা দিয়ে ঢুকছে সব স্ট্রাকচারস গুলো entering into and coming out. Okay. যেমন trachea and pulmonary artery are entering into the lung, pulmonary veins are coming out from the lung and some lymphatics are also coming out. Okay, so these structures are together forming the root of the lung. They are entering the lung through the hilum. Here hilum is gateway যেটা দিয়ে লাংয়ের ভিতরে ঢুকছে. So relations, medial relation is esophagus. Lateral relation is mediastinal surface of the lung. Superiorly there is hilus of the lung. Inferiorly it ends in a free sickle shaped contour. This is relations of the pulmonary ligament. Okay. What are the functions? Potential space. Pulmonary ligament provides a potential or dead space for expansion of the pulmonary veins. It contains loose areolar tissue, so there is space for expansion of the veins. It permits descent of the root of lung during inspiration. Pulmonary ligament provides space for descent of root of the lung and descent of diaphragm pulls the lung downward. Okay, during inspiration, diaphragm descends and along with lungs are also descending along with its roots. So this it also helps in permits the movement of the root of the lung. Next we go to the recesses, costomediastinal and costodiaphragmatic recess. Here near this region where here will be the diaphragm, dome of the diaphragm. So just above the diaphragm where the costal pleura and diaphragmatic pleura is merging with each other, at this region lies the costodiaphragmatic recess. and where the diaphragmatic pleura is continuous with the mediastinal pleura, here lies the costomediastinal recess. Okay. These are important because some collections are occurring in different diseases at this region, because these are the most dependent part of the thorax. So these recesses can come as a short note. These are important: costomediastinal and costodiaphragmatic recess. Pulmonary ligament is important mainly for viva and may sometimes can come as a short note. Okay, so recesses of pleura, these are potential or reserved space of pleural cavity that lies between parietal and visceral pleura. Function is potential space for lung expansion. What are the number of pleural recesses? Two major pleural recesses are lying on each side: costodiaphragmatic recess and costomediastinal recess. And two minor recesses are present: retroesophageal recesses, right and left, and infracardiac recesses. These two are not much important. These two are very important: costodiaphragmatic, costomediastinal. And these are small or minor recesses, retroesophageal, posterior to the esophagus on two sides of esophagus, and infracardiac just below the heart. Okay. So, pleural recesses are potential spaces of pleural cavity. Two recesses are present. Costodiaphragmatic recess lies inferiorly, lies between costal and diaphragmatic pleura. It is larger and most dependent recess. And costomediastinal recess, it lies anteriorly, lies between costal and mediastinal pleura, and left recess is larger than the right due to cardiac notch of the left lung. There is reflection of pleura at the cardiac region. And what are the function? It provides spaces for lung expansion during the deep breathing. What are the clinical integration? In pleural effusion, fluid accumulates in the costodiaphragmatic recess. You can see in the radiograph or X-ray plate, chest X-ray PA view, obliteration of the costodiaphragmatic angle. See, this is longitudinal section through the lung, coronal section mainly, and this is transverse section. Okay. So, see, this pink line is representing the lung boundary and the blue covering is the pleura. So, these parts are the costomediastinal recess, the junction of mediastinal and diaphragmatic pleura, and here it is costodiaphragmatic recess at the junction of diaphragmatic and costal pleura. So, large spaces are formed in between the parietal and visceral pleura in these two regions, and fluid accumulation occurs in this costodiaphragmatic recess. It is the lowermost position of the pleural cavity. That's why it is the dependent part, and any kind of fluid accumulation occurring in this costodiaphragmatic recess. Okay. And this costomediastinal recess, it is also occupied during the enlargement of the heart or any pathology in the mediastinum. Okay. Next we go to detailed discussion of costodiaphragmatic recess, also called phrenico-costal sinus. Phrenico means diaphragm, costal means costal, a thoracic wall. So it lies between the diaphragm and thoracic wall, that's why phrenico-costal sinus. Cleft-like potential space between the costal and diaphragmatic pleura. Length is 5 cm in the mid-axillary line. What is the location? It extends from 6 to 8 rib in the mid-clavicular line. This is very important. It is asked in your viva. What is the extent of costodiaphragmatic recess in different region? One we measure at the mid-clavicular region. One is at the mid-axillary region laterally, and one is posteriorly paravertebral line or mid-scapular region. You can see. So it extends from 6 to 8 rib in the mid clavicular line, 8th to 10th rib in the mid axillary line, and 10th to 12th rib in the paravertebral line. And it forms most dependent or lowest part of the pleural cavity. Hence, fluid in the pleural cavity in case of pleural effusion tends to accumulate in this space. Okay. See here, this is section through the thorax. This is thoracic wall containing the intercostal muscles. Okay, and this pink one is endothoracic fossa, and underneath the endothoracic fossa, the green covering is the parietal pleura, and this is lung tissue and visceral pleura. So, in between the visceral pleura and parietal pleura, this space near the thoracic wall, it is costodiaphragmatic recess. Okay. So, here it is in the mid axillary line. Here it extends from 8th to 10th rib. You can see this is 8th rib and this is 10th rib. So, the recess is extending from 8th to 10th rib. This location is important because in case of fluid accumulation, you have to drain the fluid. So, you have to do pleural tap. So, you have to do the pleural tap at this region, because if you do it at higher level, there is high chance of lung injury. Okay. So, next we go to the costomediastinal recess. It is the space that lies anteriorly behind the sternum and the costal cartilages. That recess, costodiaphragmatic recess, was lying mainly posteriorly or laterally, and this costomediastinal recess is lying mainly anteriorly. So, this space that lies anteriorly behind the sternum and the costal cartilages between costal and mediastinal pleura. Right costomediastinal recess is normally occupied by the anterior margin of the right lung even in quiet breathing, and left costomediastinal recess is larger, less occupied than the right due to presence of cardiac notch of the left lung. Okay. So, here is the left costomediastinal recess, it is larger, and this is right costomediastinal recess, it is smaller than the left. Next we go to some clinical aspects. Intrapleural pressure is always negative, minus 4 millimeter of Hg. This is important for a Viva and MCQ. What is the intrapleural pressure? Okay. And also can come as a part of long question. If mechanism of respiration comes in long question, it can come as a part of theory. Okay, so what is intrapleural pressure? It is minus 4 millimeter of Hg. It is always negative. This negative pressure helps in lung expansion. Okay, it pulls the lung towards the thoracic wall. Retroesophageal recess, this is right and left, lies posteriorly between the costovertebral pleura and mediastinal pleura and lies behind the esophagus. That is why retroesophageal recess. Next is infracardiac recess, lies only on the right side and it extends behind the inferior vena cava. Normally, pleural cavity contains 5 to 10 ml of serous fluid. Okay. Next we go to the nerve supply of pleura. Parietal pleura is pain sensitive, it is somatic supply. Intercostal nerves supply the costal and peripheral part of diaphragmatic pleura, and phrenic nerve, that root value C3 to C5, C3, C4, C5. This is very frequently asked, phrenic nerve root value of phrenic nerve, okay, C3, C4, C5. Supply the mediastinal and central part of the diaphragmatic pleura. All these are coming from somatic nerves. Somatic means it is supplying the body wall. Okay. And visceral pleura, it is insensitive to pain, supplied by sympathetic supply from T2 to T5 segment and parasympathetic supply from the vagus nerve. So, this is autonomic supply of the visceral pleura. Okay. Sympathetic, parasympathetic included within autonomic nervous system. Next we go to blood supply of pleura. Parietal pleura is supplied by intercostal internal thoracic and musculophrenic arteries, and visceral pleura is supplied by bronchial arteries. Okay, so this is the arterial supply of the pleura, and veins will correspond with the arteries. So they have same name. Okay, so here we have shown the obliteration of costodiaphragmatic recess. See, this is normal. This is in chest X-ray. Half of the chest X-ray has been shown. In this side, you can see this is normal costodiaphragmatic angle. The black portion is extending downward. Here, obliteration occurred. Okay, opacities are present. It is whitening. So here is obliterated costodiaphragmatic angle due to pleural effusion. Okay, it will look like this in chest X-ray. Chest X-ray you have to read everywhere. In every patient, most of the patient chest X-ray is needed. Okay, for during surgery, for pre-anesthetic checkup, you have to do chest X-ray, or any chest disease, you also always do chest X-ray. So pleural effusion, there is accumulation of fluid in the pleural cavity. This is known as pleural effusion. Next we go to costodiaphragmatic angle. It is the angle between the costal and diaphragmatic parietal pleura on a radiograph of thoracic region. Corresponds to the costodiaphragmatic recess, and it lies between diaphragm and the chest wall. Normally, it is sharply pointed downward and measures about 30 degree. This recess, this angle is almost 30 degree and it extends downward. Dependent or lowest part of pleural cavity, pleural effusion tends to accumulate in this site. An obliteration of costodiaphragmatic angle in pleural effusion. In pleural effusion, chest radiograph shows this obliteration or blunting or widening of the costodiaphragmatic angle. Okay, fluid will create pressure, so that's why this angle will be more widened. Okay, and there will be obliteration of the angle. Okay, here referred plane of phrenic nerve has been shown. C3, C4, C5 was supplying this mediastinal pleura and this medial part of diaphragmatic pleura, and this from this root value cutaneous supply was going towards the shoulder. Okay, so in case of some diseases in the mediastinum or pleura or diaphragm, the pain can be referred towards the shoulder, because same root value, there is same root value. So referred pain of pleura, pain arising from parietal pleura is referred or felt to the lower part of the neck and shoulder region. What is the cause? Phrenic nerve, which root value is C3 to C5, supplies the parietal pleura, and same nerve root C3 to C5 also supply the neck and the shoulder region through the supraclavicular nerve. Root value is C3, C5. So these are the supraclavicular nerve. Three supraclavicular nerves are there: medial, intermediate and lateral. Okay, so they are supplying the lower part of neck and the supraclavicular region and the shoulder region. Next we go to atelectasis or lung collapse, loss of negative intrapleural pressure. Normally it is -4 mm Hg, you have learned. So results in lung collapse. Okay, it will not be able to pull the lung towards the thoracic wall, so lung expansion will be not possible and lung will collapse due to its have own property of elastic recoil. Okay, or collapsing. So that's why the lung will collapse on its own due to recoiling property of the lung. Next is pleurisy or pleuritis and pleural rub. Pleurisy is a inflammation of the pleura. What is the cause? Viral infection is most common cause. Tuberculosis, pneumonia, pneumonia is infection of lung, and so on. These are the main causes of pleurisy. Inflamed rough surfaces of pleura produce friction sounds during respiration, and these sounds can be heard during auscultation with the stethoscope. Okay, pleural rub will be there, pleural rub, this sound. This is pleural tap, okay, aspirate pleural fluid. You can see this costodiaphragmatic recess is filled with the fluid of pleural effusion in the costodiaphragmatic recess, and it is being aspirated between the 9th and 10th rib through this space, through this needle. Pleural effusion and thoracocentesis. This is known as thoracocentesis, this process. And here it is being passed through the mid-axillary line. Okay, we have read in the mid-axillary line, the pleural cavity extending from 8th to this recess, costodiaphragmatic recess is extending from 8th to 10th rib. So, pleural effusion is an excessive accumulation of fluid in the pleural cavity. Normal amount present is 5 to 10 ml. What are the types of pleural effusion? Pleural effusion come as a short note, okay, very important clinical aspect, pleural effusion. So, what are the types of pleural effusion? It is also important during your final year medicine, okay. So, types of pleural effusion, based on the accumulated fluid, the pleural effusion is classified into these types. Hydrothorax, accumulation of serous fluid or transudate kind of fluid. Hemothorax is accumulation of blood. Empyema or pyothorax, accumulation of pus. Chylothorax, accumulation of chyle. And hydropneumothorax, accumulation of both air and fluid. Okay. What is the treatment? Treatment is thoracocentesis. It is aspiration of excess fluid from the pleural cavity. This is known as thoracocentesis. Treatment of underlying cause, and not only thoracocentesis will be helpful, because if you don't remove why the fluid is accumulating, if you don't treat the infection, there will be again accumulation of the fluid. Okay, so you have to treat the main cause. What is the procedure of thoracocentesis? It is important, sometimes comes in your theory. Thoracocentesis important in your final year. This procedure comes as a short note. Thoracocentesis. Cannula or needle is passed through the lower part of the 8th or 9th intercostal space. This is extension of costodiaphragmatic recess in mid-axillary line, and it is passed in the mid-axillary line to avoid injury to the neurovascular bundle. Okay, this is actually important for explain why question. Why during thoracocentesis needle is passed through the 8th or 9th intercostal space, and also why it is passed through the lower part of the intercostal space, because in the upper part, in the costal group, main neurovascular structure is lying. So, if you pass the needle through this, there is high chance of injury to this neurovascular bundle in the costal group. That is why the needle is passed through the lower part of intercostal space and in the 8th and 9th intercostal space. Okay, understood? So, we prepare it as a explain why question. Here pneumothorax, there is injury in the thoracic wall, and air has entered into the pleural cavity, so negative pressure is lost and lung is collapsed in this side. Okay, collapsing of right lung. Air entering in the pleural cavity through injured chest wall and pleura, flaps of injured tissue prevents exit of entered air. It will lead to pneumothorax. Okay. Pneumothorax, this is also an important clinical aspect. In road traffic injury, there is high chance of injury of rib fracture and leading to pneumothorax. So, pneumothorax is accumulation of air in the pleural cavity. It is called pneumothorax. Normally, intrapleural pressure is always negative, and because of pneumothorax, this pressure becomes positive and it causes collapse of lung or atelectasis and shifting of mediastinal content to the opposite side. Okay. What are the causes? Injury to the thoracic wall and the pleura. Here is the injury. Okay, and lung collapse has occurred. and this positive pressure will also push the mediastinal structure to the healthy side or opposite side. Okay. Next is tension pneumothorax. It is a surgical emergency. It occurs when air can enter into the pleural space but cannot escape. Okay, this injured lung tissue, pleural flap, it will act like a valve. Okay, it will open in one way. It helps in entry of air, but it will not. But escape of air cannot occur, air cannot come out. Okay, so if only entry occurring air will accumulate in the pleural cavity, it will press upon healthy tissue, healthy lung and other healthy structures of the thorax. So it is dangerous. So it occurs when air can enter. This tension pneumothorax very important short note in your final year and also can come in your theory, tension pneumothorax. It is a surgical emergency, occurs when air can enter into the pleural space but cannot escape. It occurs due to valvular air passage, one-way entry of air. Signs and symptoms, it causes collapse of lung, impairment of respiration, hyperexpansion of the chest, deviation of trachea to the opposite side. What is the treatment? It is a surgical emergency, thoracostomy you have to do. It involves insertion of needle in the second intercostal space in the mid-clavicular line. Thoracostomy is done in the second intercostal space through a needle. We have to take out this air. Okay. Okay, that's all. So, in clinical aspects, this thoracocentesis, pleural effusion, pneumothorax, tension pneumothorax, all these are important. Okay. From here, short note or explain why can come. And pleura, this recesses, costodiaphragmatic, costomediastinal recess, we prepare as a short note. And pleura individually can come as a short note. Okay. Pleura can come as a short note. You have to write the parietal, visceral pleura, divisions of parietal pleura like this. Okay, understood? So, yes. No, air will escape and lung collapse will reverse. Okay, the positive pressure will reduce in the pleural cavity, so lung can expand during inspiration. Lung will expand. হ্যাঁ ওটা তো থাকবে, ওটা তো রিপেয়ার করতে হবে, যতক্ষণ না রিপেয়ার করা হচ্ছে ওটা হচ্ছে ইমিডিয়েট ট্রিটমেন্ট। অনেক মানে দেয়ার ইজ ইট টুকস টাইম না ফর দ্য সার্জারি, সো টিল দেন you put the needle and create a artificial passageway for the air. Okay, and after the surgery completed, needle is removed. Needle is also dangerous. Na? Needle can pierce through the lung tissue. It can injure important structures. It is temporary relief to the patient. Okay, so that patient cannot die. Okay, understood? Okay, so thoracostomy is done in second intercostal space in mid-clavicular line, okay, and thoracocentesis is done in mid-axillary line in 8th to 9th intercostal space. This is important, okay.